Continuing from the spinal cord and spinal nerves chapter, we move to chapter 14, which is the brain and cranial nerves. So in this chapter, we'll talk about how the brain is organized. We'll talk about what kind of structures will protect the brain and how it keeps the blood supply flowing, how certain barriers prevent certain types of infections throughout the brain, and how small types of substances can actually influence the brain in certain ways, including alcohol and certain types of drugs. We'll talk about the different areas of the brain, how they communicate, how certain areas of the brain will have different types of functions. We'll talk about different types of orders of the brain and how different signals are going to be interpreted and how they're going to be projected outward. And we'll talk about certain types of diseases or dysfunctions of the brain. We'll talk about the 12 cranial nerves, where they originate, and basic kind of function that they hold as well. Some of which will be very familiar to you as you came off of the muscle chapter a few chapters ago. Some of the cranial nerves will be either purely motor, purely sensory, or a mix of the two. So let's look at the major sections of the brain here. Now if we continue up from the spinal cord and go next superior structure, you're going to find what's called the brain stem. It's going to be made up of 3 different parts. The first little swelling you see in the anterior is going to be the medulla oblongata, followed by the pons, which is the major swelling you see just superior to that. And just superior to that will be the midbrain. If you look just posterior to that area, you see almost like a cauliflower, almost like a broccoli-looking piece of the brain. That's called the cerebellum. You're going to see different white and gray matter in that particular structure. That's your major balance and coordination center for all the motor functions. If you go just superior and anterior to that, you're going to find what's called the Diencephalon, which kind of is a misnomer. You think di, you mean 2, but there's actually 3 different structures found within Diencephalon. First, you have the major relay center of the brain, which is called the thalamus, and next you find the hypothalamus, which is the major homeostatic portion of the brain, and finally you have the pineal gland, which is part of the epithalamus. This is your sleep center, as well as a couple other functions for the epithalamus. Now that is surrounded by the cerebrum, which is going to be where most of the primary motor centers, the primary sensory centers, as well as for personality. We'll talk about the different lobes of the cerebrum later on. If I want to point out the pituitary gland, which is going to be the extension of the epithalamus, which is going to sit in the sella turcica, found in the sphenoid bone. So the brain will be protected by a couple different structures here. First, you find the cranial bones, that forms the cranial vault, which you should be very familiar with when we looked at the axial skeleton. Plus, you're going to have the cranial meninges, which are going to be continuous with the spinal cord meninges. You have a pia, an arachnoid, and a dura mater. The only difference with the cranial mater is you're going to have 2 different layers, which I'll show you in a couple slides here. One is going to be the periosteal layer, which will be closest to the actual bones of the cranium. Maybe the meningeal layer is closer to the actual meninges themselves. You will have cerebrospinal fluid, also be continuous with the spinal cord, but we're going to look at certain structures that will actually create the cerebrospinal fluid, and also look at how it's filtered, or have blood, is actually filtered through to comprise the CSF, and where it's actually stored in different types of structures or canals all throughout the brain. Here's a nice little coronal section of the cranial bones and meninges. You see the parietal bone here. You can see the 2 layers of the dura mater. You're going to find the periosteal layer, which of course is going to be up against the periosteum of the bone, followed by the meningeal layer, which is closer to the actual meninges themselves. In between the dura mater and the arachnoid mater, you find the subarachnoid space. So you find arteries and veins that help supply the brain tissue just deep to that. But one little structure that you may not be familiar with are the arachnoid villi. It's going to be very important to maintaining the correct amount of cerebrospinal fluid that bathes the entire region around the brain, also the spinal cord. You'll see here you have what's called the superior sagittal sinus. This is a major reservoir or a part of the venous system here. A lot of times when this gets backed up, this can cause different types of headaches, especially we'll call coronal headaches, which are around the corona of the head, like a hat band type of a headache. A lot of different techniques that we use, also massage techniques, help kind of release some of the pressure off the sagittal sinus. More of the times than not, most people wind up taking some kind of anti-inflammatory like ibuprofen, or taking a leave, or take a vasodilator to help kind of loosen up the flow a bit, like Tylenol. Another thing you'll see here that you probably haven't heard before is called the falx cerebri. There's going to be an extension of the dura mater that's going to basically split the two hemispheres of the brain, and we'll look at a different function or a different portion of it here called the falx cerebellum, which is going to partition the cerebellum from the rest of the brain. Here's the extension of the dura mater here. So the falx cerebri is going to be in a sagittal position, mid-sagittal, so it'll separate the left and right hemispheres. That's going to be continuous with the tentorium cerebelli, which is going to basically partition the cerebellum from the midbrain and the rest of the cerebrum. There you see the falx cerebelli, which is going to be just posterior to the cerebellum, will protect it from the occipital bone. Basically, you'll see the straight sagittal sinus right through here. You'll find transverse sinus that actually will going from left to right. These are the major areas that draw blood flow away from the brain. Just like the rest of the venous system found in the body, it is a reservoir system, so it does get backed up from time to time. It can be a major cause of headaches. So we touched upon just a bit. We looked at the vertebral column. We talked about the vertebral foramina found in the cervical vertebra. Other than that, we really didn't touch too much about brain flow or blood flow to the brain. But very simply, you've got a couple different avenues to supply the brain with blood. So if you start with the brachiocephalic trunk, see how it partitions off, and you're going to see the right vertebral and the common carotid extend superiorly up into the brain. But I want to point out to you as well, you have the right subclavian and the right axillary arteries through there. Notice how it goes between your clavicle and between the first rib there. This can get pinched off pretty easily from poor posture and injuries to the shoulder, injuries to the clavicle, especially if you ever broken the clavicle before. This causes a phenomenon that we know is called subclavian steel, where a lot of times if there's not proper blood flow to the right arm in particular, you don't see as much on the left arm, just by virtue of how the brachiocephalic trunk branches closer to the right than to the left. But what will happen is the right upper extremity will start drawing blood away through the right subclavian artery, which will pull blood away from the right vertebral and the carotid arteries. So this can cause some issues, especially with lightheadedness, especially if there's any kind of occlusion on the left side of the vertebral or carotid arteries. Some people can pass out pretty easily. But if you notice, the right vertebral artery basically kind of skirts right through the foramina as it supplies up to the brain. You see the right common carotid artery and right external carotid artery basically as it flows up the lateral portion of the jaw up into the head. So these are your major arteries that are going to supply blood to the brain. This will be covered a little more so in HAP 2, so we're going to lightly touch upon this as it regards to CSF, and then naturally all this will flow back out of the brain through the jugular vein and then back towards the heart again. So even though the brain is only roughly 2% of the body's weight, it utilizes about 20% of the body's oxygen supply. And as we know, any kind of interruption to the oxygen supply can result in some kind of necrosis of the brain, some death of brain cells. It only takes 1 to 2 minutes worth of lack of oxygen cause impairment, 4 minutes permanent injury, and a lot of times this can be detrimental, of course, especially in certain areas of the brain, if it deals with certain types of smells or certain types of personality, anger control, that kind of thing, and this can really severely impact the person's life. Also, this also supplies glucose to the brain, aside from oxygen. There's no glucose stored in the brain. It's in constant supply. Of course, many of you can attest to this, especially if you skip breakfast and try and take some kind of exam. You may notice that trying to remember certain things or a little bit confusion, you might feel lightheaded, you might feel sick to the stomach. This can all be paired with the glucose deficiency. So that's why it's always important to maintain a steady, healthy diet throughout the day. And of course, too much glucose can also have some adverse effects as well, not so much with the brain, but other parts of the body. But with severe glucose deficiency, it can cause convulsions and also make you pass out. So obviously that blood is very important as a supply chain to the brain. But you also need a very selective barrier to help protect any kind of substance from traveling into the brain area. So thankfully we have a very special barrier simply called the blood-brain barrier, which is built up by epithelial cells that are adhered together by tight junctions that surround all the capillaries. So basically prevents different types of structures that pass into the area. Obviously, it'll let through very small molecules like oxygen, carbon dioxide. Glucose also passes very freely through there, but also helps block any kind of entry of certain viruses or bacteria, certain types of drugs. But a lot of times, if there is any kind of injury to the blood-brain barrier, this leaves things open to infection very easily. Now, there are other certain things that can also pass through relatively easily through the somewhat of a selective barrier. Includes the oxygen and carbon dioxide, alcohol, different types of steroids, certain types of barbiturates are permeable. The barbiturates in particular are helpful or very calming effect for anti-anxiety drugs or antidepressants. But occasionally, if you need other therapeutic drugs to pass through, a lot of times they'll actually will inject them, whereas sometimes will take them with a very high glucose solution. Because a lot of times we'll see, especially when we saw passive transport way back when, the glucose molecules going from high concentration to low concentration will carry some of those molecules of therapeutic drugs in through the blood-brain barrier. Plus, there's some other types of drugs too that help kind of loosen up some of the tight junctions and therefore allow certain drugs to pass through as well, although it does make the brain a little more susceptible to any other kind of injury and or infection. So the CSF, or the cerebrospinal fluid, that's the liquid that's going to bathe the entire brain and spinal cord. Basically helps keep a very safe chemical environment. Also acts as a cushion against any kind of physical injuries. For most people, a very common injury is concussions. Obviously, the CSF is also very important for carrying nutrients such as oxygen and glucose, and also help kind of draw away any kind of waste products. This is basically formed by ependymal cells that form the tight junctions that would be just inside the pia mater to allow the CSF to be both produced and also drawn away from the arachnoid villi. Very simply, these are stored in what we call ventricles found in the brain. We have two lateral ventricles. You have a left and a right, which is the most superior. You have the third ventricle, which is going to be connected by the interventricular foramen. And finally, it's going to attach to the fourth ventricle by what's called the aqueduct of the midbrain, called the cerebral aqueduct. And then further down, as it travels to the spinal cord, it's going to go through the median aperture. I've had a few patients that have had difficulty with CSF buildup. One patient in particular had a narrowing of her cerebral aqueduct, had actually go in surgically, had them artificially widen it for her. She was getting massive headaches, pressure headaches. That was not relieved by any kind of drugs or any kind of therapy. So they finally did a CAT scan and actually saw there was narrowing of that particular aqueduct. So as you can imagine, it's a somewhat of major surgery, even though it was a very simple incision. They went in deep, I believe through the occipital lobe, I believe, to try and release some of the pressure and open up the valve, or open up the actual aqueduct. So there are certain kind of things that can happen with CSF. We'll see actually how it's produced, how it flows, and what special structures are found therein. But the CSF has to be maintained in a certain volume, also certain pH as well. So the ventricles will contain the CSF, but what's called the choroid plexes will actually produce CSF. And you're going to find them within all four ventricles, both laterals, the third and also the fourth ventricle. So as you can see on the diagram, on the upper right-hand side, you're going to see the ependymal cells with the microvilli there. They're going to be connected by tight junctions. What will happen is it will get blood flow from the capillary at the choroid plexus. It will filter through the ependymal cells and produce the CSF. So again, ventricles will contain CSF. The choroid plexes will produce CSF. So looking at how CSF flows, we're going to start ourselves actually at the heart and lungs. So let's go over to the right diagram, start at the bottom there. Start with the heart and lungs as it pumps arterial blood up through the brain area, through the carotid artery, and also the vertebral artery. It will pass through the choroid plexes of each of the ventricles. So as you can see in the corresponding lateral, third and fourth ventricles, you're going to filter and have the CSF produced. So from the lateral ventricles, it's going to go through the interventricular foramina, down to the third ventricle, down to the cerebral aqueduct of the fourth ventricle. It's going to go through the lateral immediate apertures to what's called the subarachnoid space. And that's basically going to flow the entire length around the brain, all the way down through the spinal cord, through the lateral, through the central canal, and then back up. And it's going to be absorbed through the arachnoid villi of the durovenous sinuses. And of course, the venous bill will travel back over to the heart and lungs. So if you look at the diagram on the left, again, starting for the most part at the lateral ventricle, you're going to see the choroid plexes are going to start with the CSF flow and follow the purple flow there. You're going to see it flow through the lateral to the third to the fourth ventricles. It's going to supply all the major parts of the brain stem, and the cerebellum. It's going to flow downward and through the actual spinal cord into the central canal, all the way down through to the filum terminale. It's going to start trekking its way back upward through the anterior part of the spinal cord, as well as to the anterior portion of the brain. It's going to start being pulled back in by the arachnoalveoli through dural venous sinuses, all throughout the periphery of the cerebrum. So first critical thinking question. CSF production and absorption rate is somewhat equal, keeping CSF pressure and volume relatively the same at 80 to 150 milliliters or 3 to 5 ounces. What symptoms would you expect to occur if there's a sudden increase or decrease in the CSF? So let's start with decrease first. So if a certain amount of CSF is actually leaked out, or let's say it's pulled out through a spinal tap, occasionally you have what's called a lumbar puncture headache. It's not a migraine, but what happens is that decrease in the CSF, too much is drawn out, creates a negative pressure on the meninges, be very painful, can actually cause a lot of disruption as far as any kind of neck movement or spinal movement there as well. But thankfully the CSF does replenish fully within about 8 hours or so. So a lot of times lumbar puncture headaches are relatively short in duration, but they can happen. But occasionally though, especially if the spinal tap is done, or let's say if there's any kind of leak through CSF, which can be a very, very problematic issue. If there's any kind of leak, then a lot of times it may take a little bit longer for that CSF to replenish and for that wound to heal. Sometimes they may use a blood patch to try and stop any kind of CSF flow. But unless you have like a really traumatic accident, you usually don't see this very, very much in day-to-day life. Now on the flip side though, when you have too much CSF, there's a couple things that can occur. Number one, you have too much CSF, it actually have too much water pressure there, and as we know, you can't compress water. There's only so much volume that the subarachnoid space can hold. So if you put too much water in there, very simply like trying to fill up a water balloon, it doesn't stretch once it gets past a certain point. So what happens is the area becomes very rigid, so it becomes very, very uncomfortable to move your head, your neck, or any portion of the spinal column. In fact, we use a certain thing in practice called Nafzicker's test, where we have a person lay supine, which means laying face up, and we very simply will flex the neck and head forcefully and see what happens. And basically the patient will usually yelp out in pain. That's our first inclination that there's something wrong with the CSF. Usually what that means, a quick trip to the hospital for them to do a CAT scan and then do some kind of spinal tap, strangely enough, try and check the CSF and see what's going on, see if there's any kind of infection. We also have hydrocephaly, which is just swelling in and around the brain. Also a very problematic kind of issue. We see this quite often with head injuries, whiplash, and some sports injuries there too. Now this slide will take you to a couple different slides of gross anatomy for the areas of the brain, including the cerebrum, the brainstem, the cerebellum, as well as different spinal nerves, the spinal cord, and also different cranial nerves, all 12 of them. So I'll show you a representation of each nerve as well as where it branches off on an actual cadaver as well. So this is actually just the second half that we guys looked at on the spinal nerves and spinal cord anatomy overview back in the last chapter. So working our way superior from the spinal cord, we're going to come up against the brainstem, which is going to be composed of 3 structures. So starting from the most inferior is going to be the medulla oblongata, followed by pons, and then followed by the midbrain. Now you'll see the same picture on the anatomy overview you just came from Wiley Plus. You're going to see different portions of the cranial nerves going to branch off, not in its entirety, but it's going to be down by the stalks themselves. They're going to branch off each individual portion of the brainstem, and in the case of 2 cranial nerves, they actually branch off not off the brainstem, but off the cerebrum themselves. We'll go through each one in just a couple seconds. So looking at the medulla oblongata, starting from the spinal cord level at the most inferior portion of the slide here, it's going to travel superiorly, and you're going to see continuation of 2 tracts there at the bottom, the anterior and lateral corticospinal tract axons. Now if you remember, corticospinal means it travels from the cortex to the spine, so these are going to be descending motor tracts. Now as you can see, a little further up, it actually will decussate, which means crossing over of the pyramids. So this is where a portion of the brain, where the left side of the brain is control a right side muscle or gland, and vice versa. So we're going to cross over for the voluntary pyramids at the decussation right through here at the medulla. You're going to see certain cranial nerves going to branch off here. There's one that's not shown. So let's work backwards from the 12 cranial nerves, starting off with 12 first, the hypoglossal nerve. And if you follow the hypoglossal nerve as it travels back the axons, you're going to find the hypoglossal nucleus. That's going to be where the nerve cell bodies will be found in the central nervous system. And if you go just behind that, you're going to see what's called the olive. This is going to include the olivary nucleus, as well as the red nucleus. These are going to be sensory and motor nuclei. The red nuclei we'll talk about is a motor connection, involuntary, which we'll talk about on the next slide here. If you go further back, you can see the vagus nerve and also the vagus nucleus. So that's going to be the dorsal motor portion of the axons and the cell bodies. And of course, you can see the fourth ventricle just terminating there. And you see the choroid plexus just peeking through on the cross section of that particular slide. Now, so branching off the medulla oblongata, we're going to find 5 cranial nerves. So the bottom 5, starting with cranial nerve number 12, which is the hypoglossal, followed by cranial nerve number 11, the accessory, which remember will innervate the trapezius as well as the sternocleidomastoid. Cranial nerve number 10, known as the vagus nerve. We'll go through these a little more so on the latter portion of the chapter. Known as the wandering nerve, basically controls the heart as well as a bunch of gastrointestinal organs that controls motility and secretion. Glossopharyngeal, which is going to be a mixed sensory and motor nerve for the muscles and taste sensations for the tongue. It's the cranial nerve number 9, and followed by the vestibulocochlear. Only the one portion is going to be innervated through the medulla oblongata. The other half of it is going to be split to the pons. So the cranial nerve number 8 will originate from both the pons and the medulla oblongata. So as we saw, different structural regions in there include the pyramids. These are going to be the voluntary motion areas for the limbs and the trunk. The olivary nuclei are going to include the sensory cortex as well as the red nucleus. We'll see why it's called red in a few seconds here. It also actually receives innervation from the spinal cord. Now, what's important about the medulla in particular is any kind of injury to medulla can affect areas for heart rate, respiratory rate, vasoconstriction, deglutition, in other words, difficulty swallowing, coughing, which can be either no coughing at all, which can be an issue, or uncontrollable coughing, vomiting, sneezing, or excessive hiccuping. So the vomiting in particular, that's very important with people that if we suspect any kind of brain injury, most people, if they're injured in some kind of with a head injury in particular, whether it be a concussion, a car accident, sports injuries, a lot of times when we see the patient vomit once, not a big deal. If they vomit twice in quick succession, that usually means that it's a severe injury to the medulla oblongata, which is a very problematic issue because it usually means one of the other functional areas there could also be detrimental as well, besides the vomiting. So again, when we look for any kind of problems with the medulla oblongata, we look for problems with controlling heart rate, respiratory rate, problems with vasoconstriction, deglutition, or any kind of problems with uncontrollable coughing, vomiting, uncontrollable sneezing, and hiccuping that simply doesn't go away. Usually we're sending for some kind of x-ray and a CAT scan to basically address any problems with the medulla. Just superior to the medulla oblongata, we'll find the pons, which is the major swelling you'll see on the brainstem. This is going to be the major relay station for linking the spinal cord and the rest of the brain by way of tracts. This will work in conjunction with the thalamus for relaying different impulses, both from the motor and the sensory. It's for the integration centers. The ponti nuclei are going to be full of gray matter for synapses, to and from the different areas of the cerebrum as well as the cerebellum. This will work in conjunction with the medulla oblongata for different impulses from the vestibular nuclei. So these are basically sensory pathways to the brain, and is actually the area where you start to store or actually create different learned functions of doing different types of muscle activities, or when you're learning new motor skills. The pons helps coordinate a lot of these different structures through the sensory as through the motor. So the relay pathway we looked at when the person was holding the pencil, this is going to travel through the pons, where it's going to associate with different areas of the medulla, the cerebellum, and also different parts of the cerebrum. So the cranial nerves, they'll branch off the pons. We, again, work backwards a bit. So we're going to work from the most inferior to the superior. You have the vestibular branch found from the vestibulocochlear nerve, cranial nerve number 8. The cochlear area will derive off the medulla oblongata. We'll find the other nerve cell bodies of the facial nerve, cranial nerve 7, which remember any kind of facial move that you make is controlled by the facial nerve. You have the abducens nerve, which remember will take care of the lateral rectus of the eye. That's cranial nerve number 6. And of course your trigeminal nerve, cranial number 5, which is very important for sensory information from the face, but also controls the jaw muscles, the temporalis, the master, and both the lateral and medial pterygoids. So these areas, from a functional standpoint, will relay nerve impulses for muscle movements from the cerebrum to the cerebellum regarding to skeletal muscle. Also, this controls both the pneumotaxic and apneustic areas. So this controls the depth of respiration, whereas the medulla will control the rate of respiration. So very distinct kind of separation of functions there between the pons and also the medulla. So the midbrain, also known as the mesencephalon, is going to be just superior to medulla oblongata and extend off of the pons through the diencephalon. So it's going to have a lot of different structures here. This one in particular, we're looking at the posterior portion through here. So we're going to have different areas such as the habenacula nuclei. You're going to find portions of the thalamus through this area, as well as you look at the different tectum, both the superior and inferior colliculi. These are very important because one area, the superior, takes care of sight. The inferior is very important for hearing. This area that helps you locate, especially having 2 ears on either side of your face. Basically, that will help time the difference of how quickly sound will travel to one ear versus the other, so you can detect where the sound is coming from. There's actually a test that we use. We get into the sensory lab where we start to show the dropping of a ruler, and we basically time it or measure how quickly we can actually capture the ruler once it's dropped. We're going to use a command word and see if that actually makes it more difficult or easier to actually grasp the ruler. There's actually a very good Brain Games episode, which unfortunately it escapes me which episode it is, but they test how well both the superior and inferior colliculi actually work in conjunction with one another. Followed by that, you have the medial genicular nucleus, the cerebral peduncle there. Then you have different nerves that'll branch off there as well. The trochlear nerve is going to branch off most superiorly. You drop it a little further down, you're going to find both the facial and the vestibulocochlear nerve. And then once you get down in towards the pons medulla oblongata, you're going to find the rest of the cranial nerves all the way down to cranial nerve number 12. So in midbrain, we have two nerves that will branch off here, cranial nerve number 3 and 4, so the oculomotor and the trochlear. Remember, the trochlear nerve is going to innervate the superior oblique, whereas the oculomotor will control the other 4, which will be the medial, inferior, superior rectus, and also the inferior oblique. This we're going to find the reg nucleus that we had talked about from the medulla oblongata, which is going to travel up from the olivary areas. The cerebral peduncles are going to include the tectum, which is going to include the colliculi, which is mentioned before. Another very important portion here, I know the diagram is a little small, we're going to look at this again, slightly larger picture in the next slide. The substantia nigra is very important because this is going to secrete dopamine. You're going to find the red nuclei because there's going to be a very high blood and iron content found therein. It's a very dedicated motor pathway for the spinal cord. Different functional regions are going to include motor impulses that can travel from the cerebrum to the cerebellum and down to the spinal cord. It's going to send the sensory impulses from the spinal cord to the thalamus, and it also regulates the auditory and visual reflexes as well. So these are very important, especially from an evolutionary standpoint, especially with us having binocular vision. Not only can we detect sound waves as the difference from one ear to the other, but also the binocular vision, the visual reflexes, be able to train our eyes very quickly to the direction of a sound and or to focus on things that are very close to us or very near to us. So the midbrain is very important for regulation of both auditory and visual reflexes, which we'll test a bit in one of the later labs. Here's a better diagram here. So you can see the aqueduct of the midbrain, also known as the cerebral aqueduct. You can find the tectum, that can be found on the posterior portion of the midbrain. The reticular formation, as we see there. You're going to find the red nucleus, and a portion of the oculomotor nerve is going to actually transmit to the anterior towards the eye, and there you see the darkened area, which is the substantia nigra. You're going to find all of the motor tracts, the descending tracts in the cerebral peduncles, including the corticospinal, corticopontine, so those areas that are going to go from the cortex to the pons, and the corticobulbar axons. Now, we find one particular structure deep within the brain stem, so it's going to actually form from different areas of the midbrain, the pons, and the medulla oblongata, known as the reticular formation. This is going to form what's called the Reticular Activating System, or the RAS. This is going to help regulate muscle tone. It's going to alert the cortex to incoming sensory signals, with the exception of smell. Smell is going to be off a different branch. So this is very responsible for maintaining consciousness and awakening from sleep. Helps maintain your attention, and also prevents sensory overload. So this will inhibit certain types of neurons, or certain types of flow, so you don't overload with different types of sensory, whether it be pain, whether it be too much light, chill, too much heat, so on and so forth, up to a certain point. Now, it's very interesting that the reticular activating system is simply this. One of the things that we know for a long time now, especially with fire alarms, is you don't usually wake up from an abnormal smell. However, certain sounds and certain touches can wake you from sleep very, very quickly. So what a lot of different companies now are doing with the fire alarms is, besides actually setting off an alarm, we are very receptive to hearing our own name. So what some companies are doing is you're allowed to program your fire alarm system to say your name over and over again, including other names of people in the family, to wake them up very quickly and get them out of the sleep pattern, get them out and get them out of the house. So it's a very interesting thing to see how the reticular activating system is being tested with those particular types of apparatus. So as you can imagine, and we'll answer a question of this later on, if there's an injury to the RAS, a lot of times we have problems either rousing someone from sleep, we may have problems falling asleep, or a lot of times they get overwhelmed with all kinds of different types of sensory information. Too many people talking at once, loud noises, too much light. A lot of times, the body cannot compensate. It's usually because the RAS is being affected in some way. So again, critical thinking. So if we had any kind of damage, whether it be a stroke or a lesion, meaning any kind of tumor, whether it's benign or even malignant, to the reticular formation, what kind of symptoms would you see? So very simply, everything I just mentioned before. So it has anything to do with sleep, and there are problems with falling asleep, or problems trying to rouse someone from sleep, you suspect a problem with the RAS. If they have problems with attention, or if they have problems with trying to analyze certain things over time, they'll often may suspect a problem with the RAS. Now, if you had damage to the medulla oblongata, that's something very specific. As I mentioned before, if there's any kind of damage there, you may see something very erratic, say uncontrollable hiccups. They may have problems breathing, trying to catch their breath. They may have problems taking a deep breath, although that may also mean there's a problem with the pons. Their heart rate may spike, or the heart rate may drop dramatically. If they vomit more than a couple times within minutes, that's usually a very sure sign there's a problem with the medulla oblongata. Most of you had stomach viruses before. Usually you'll throw up, once or twice, and then about half hour later, you may vomit again. But when there's a rapid succession of vomiting, then usually it's saying some kind of damage to the medulla. So here's a little cheat sheet for you guys to kind of go over what we just talked about here for all three parts of the brainstem. So the medulla, the pons, and midbrain also gives a nice little synopsis of what cranial nerves will branch off each portion of the brainstem. So the cerebellum is going to be found in the posterior and inferior portion of the cranial vault. It's going to be partitioned into two hemispheres, left and right, each with its own lobe, both an anterior and a posterior lobe. It's going to be partitioned by what's called the vermis. This is one of my favorite portions of the brain because it has a lot to do with balance and coordination, something we use very much so in our practice. Here's the mid-sagittal section of the cerebellum. As you can see, it rests just posterior to the fourth ventricle, so it has a steady supply of CSF. It's going to have a very strong correlation with the pons as well as the thalamus. So this is going to create skeletal muscle contractions, also maintenance of posture, tone, and balance. So see a lot of interconnections in through here. Damage to the cerebellum can be very, very traumatic, especially with any kind of issues as far as concussions. But it's also very susceptible to alcohol intake, and also with certain types of drugs can really interrupt any kind of coordination with the cerebellum. We oftentimes see different types of gait patterns with the damage to the cerebellum. One in particular is known as ataxia, which is a lack of ability to actually a coordinated motion. So we have what's called an ataxic gait. This is one of those things where someone has a very awkward type of motion. We have what's called a slappage gait sometimes, or it almost looks like you can imagine a baby first learning how to walk, especially in an adult. That's what's known as an ataxic gait, where it's not very controlled, it's not very smooth. It's probably the best term I can get for it. Other kinds of damage to the cerebellum, as we know, any kind of gait patterns or any kind of fine motor control, which include any kind of writing issues, any kind of sport issues that we're familiar with, shooting a basketball, throwing a ball, swinging a bat, that kind of thing. But one thing that people don't usually think about is speech patterns. Now, speech can be susceptible to a lot of different types of problems. One in particular, obviously, it requires very fine motor control. The cerebellum, if there's injury to that, a lot of times you may lose very fine motor control, so you may speak very much the way I do. You may slur your speech when they're very excited, or have a very fast type of speech there as well. Obviously, alcohol and different types of drugs can also inhibit the function of the cerebellum, and also start to lose control. Different types of disease processes, which include multiple sclerosis and Parkinson's, which will be different types of tremors. Multiple sclerosis is identified by what's called intention tremors, where at rest the person does not have any kind of outward sign of an injury, but if they try and do something, like reach for a pen, you'll see shaking in the hand, which usually means that there's basically loss of the myelin sheath around the axons. Parkinson's is just the flip side. Parkinson's has resting tremors, but a lot of times Parkinson's, when you are actually ready to do motion, actually you find it actually moves very smoothly. So when the muscles are active, it has a better connection to the cerebellum. But resting, though, the Parkinson's causes fasciculations, or the swaying motion back and forth of certain muscle groups. So we use different types of tests. And hopefully, if you've never had any kind of a drunk test done, these are kind of the same tests you'd use there too, that we use in practice, such as neurological tests. So this is a typical one where you close your eyes, tilt your head back, and very simply have your arms outstretched, and take your index finger, touch your nose, and bring it back out again. Other tests will simply be just standing on one foot. If you want to check or really kind of challenge the cerebellum, which unfortunately I won't be able to bring in because it won't be on campus anymore, is you have people sit on exercise balls or balance boards and see if there's any kind of deficiency to one particular spot towards the body, one direction. But there's all kinds of things we can test neurologically, very simply in the office, to see if there's any problem with the cerebellum itself. But naturally, you need x-rays, CAT scans, MRIs to really kind of see and get an idea of whether there's any kind of lesion there or any kind of necrosis in the cerebellum. Okay, Diencephalon, we're just going to find just superior to the brainstem, and it's going to be the deepest part of the brain. It's going to be comprised of the thalamus, hypothalamus, and the epithalamus. The epithalamus will include the pineal gland. So the thalamus is the basic relay station for all your sensory impulses except smell. So this basically will take all information from the periphery, and it'll take things from the supracortex, feed to what's called the limbic system, which we'll get to in a little bit. That's the most primitive part of your brain, and also to the cerebellum. Now, one thing I want you to be aware of, if you look at the diagram on the right-hand side, letter C, I'm not going to test you on that. There's a lot of different nuclei found there. I think it's just a little bit too much to throw at you in this particular course, especially now as not being on campus. So very simply, I won't test you on this. I very simply want you to know the thalamus, and we'll see this very astutely when we look into the integrative systems in the following chapters. I believe it's chapter 16. We're going to really kind of focus on the thalamus then, but not for this chapter. So just very simply know that it's a major relay station for everything except for smell. Smell goes directly from the olfactory nerve right to the cerebral cortex. Now the hypothalamus, I am going to test you on this only because of the 4 regions. I don't expect you to know all the different nuclei that make up the regions, but the regions are very important, and from the sense where I want you to know what particular regions control what particular types of homeostatic conditions found in the body. So this is the major regulator for homeostasis, is the hypothalamus. So you can have 4 regions: the mammillary, the tuberal, the supraoptic, and the preoptic region. So the mammillary region is going to be the most posterior. These are going to be your reflexes due to scent or olfactory. Your tuberal region is going to be mostly for, it's going to connect to the pituitary. So naturally, the hypothalamus will control the pituitary gland. The supraoptic is going to be just superior to the optic chiasm. This is going to connect to the posterior pituitary in particular by hypothalamic hypophyseal tract. So there's a little stalk, a little portion there you see just by the infundibulum right down through there. And finally, the most anterior is going to be the preoptic. This is going to regulate the majority of your autonomic activities. So blood pressure, heart rate, pH balance, all the major homeostatic activities of the autonomic nervous system is going to be channeled through the preoptic region. And there's a list of the 4 regions here again. So you have mammillary, again, the most posterior. This is going to deal with all the reflexes due to smell. Tuberal connect to the pituitary. Supraoptic is going to connect to the posterior pituitary, to the hypothalamic hypophyseal tract. Then the preoptic will regulate all the autonomic activities. So again, know the 4 regions and know what they do in particular. Most likely I will not actually test you on exactly where they are, but I want you to know, at least know what the regions do. So as we know, the hypothalamus has a bunch of different functions with the autonomic nervous system. So it's control smooth muscle, cardiac, gland secretion, heart rate, visceral regulation, and the urinary bladder, up to the point where it's going to secrete or release urine. Naturally, we know there are external urethral sphincter that allows the actual flow. So this is where the internal urinary sphincter is going, urethrosphincter is going to be fighting against you, especially if you have a full bladder. Naturally, the hypothalamus is going to be very important for the production of hormones, both from the release and also the inhibition standpoints. This will aid in both emotional and behavioral patterns. This is also where the eating and drinking functions will apply. If you remember the neurotransmitter and also the hormones that we saw back in the last chapter for feeding, satiety, hunger centers, there's what cholecystokinin is going to be released. This is where neuropeptide Y as well as angiotensin II, both for hunger and also for thirst. And naturally, it's going to be the body's thermostat. It's going to regulate the body temperature. And finally, we're going to look at very briefly different circadian rhythms. So our sleep cycles, our wake cycles. A lot of these will be working, especially in conjunction with the reticular system. The hypothalamus will help control that as well. So the epithalamus, this is very important, especially with senses as far as smell. Very important for connection to emotional responses. So this also will connect with the pineal gland that helps secrete melatonin, as well as it works with habenular nuclei, especially with olfaction. So those you may, if you remember, especially when you're growing up, like walking into, let's say, your grandmother's house. Now for me, living with Italian people, we would smell either mothballs or you smell gravy on the stove. And we're talking about tomato gravy, not the brown stuff. For some people, maybe walking and smelling apple pie or smelling your grandma's perfume, that kind of thing. There's a very strong response to the olfactory stimuli to certain types of emotions. Some people, it might cause anxiety. Some people, it may cause a very strong sense of relaxation. So a lot of times you'll notice different kind of odors in certain kinds of residences in particular. Or let's say some people walking to a library, some people get that smell. And again, some people get very anxious, some people get very relaxed. There's also a very common phenomenon where people walking into a library, they smell the books, and all of a sudden they feel like they have to go to the bathroom. Usually some kind of bowel movement, that kind of thing. It's a very strange phenomenon that's under research right now. Also, different types of perfumes of a loved one, or certain types of colognes from a loved one, can also instigate some very emotional, deep-seated responses. So one portion of the diencephalon I want to reinforce to everybody is the circumventricular organs of the diencephalon. These are very important because these help monitor different structure or chemical changes in the blood itself. There's no blood-brain barrier here, so this is almost like one of better terms, almost like a dipstick type of sense of what's going on through the blood. This will help kind of coordinate different type of homeostatic activities through the endocrine and the nervous system. So this one regulates different types of fluid bounces, helps regulate different areas as far as electrolyte bounces, neurotransmitters, glucose, what have you. So very simply, this will look at different areas of the blood as far as viscosity or specific gravity. If, say, is the blood too thick or too thin, this can actually trigger certain types of neurotransmitters, like we talked about before, the angiotensin for thirst to draw in some more fluid back into the body, or hunger with neuropeptide Y. But again, these will aid the hypothalamus in particular, and also the pineal and pituitary glands by helping coordinate homeostatic activities through the endocrine and the nervous systems. So this is both a fast-acting type of sensory organ as well as a long-acting. So working with the very quick acting of the nervous system and the very slow acting of the endocrine system by releasing different hormones to allow the body kind of react itself to bring it back into homeostasis. So here's a little cheat sheet for you to look at the three areas of the diencephalon: the thalamus, hypothalamus, and the epithalamus. Tells you what structures are found therein and also the basic functions. So we come to the cerebrum. So the cerebrum is going to be composed of mostly gray and white matter. The gray matter is going to be found in the periphery of the cerebrum. You're going to find different types of structures that have all kinds of infoldings of billions and billions of neurons. You're going to find different types of things like gyri or fissures or sulci all throughout the cortex. We're going to see the importance of having these structures there in particular, and how sometimes if we see a lack of those structures, usually means a lack of development in the brain. So now deep to the cortex, and you're going to find a lot of white matter. These are very important for different types of tracts and try and use different interconnections within the brain, whether it be within the same hemisphere or whether to the same hemisphere on part of the hemisphere on opposing sides, or actually areas from the spinal cord that track up into the cerebrum. These are made possible by what's called the corpus callosum, which is going to be the major bridge that's going to collect those tracks between both hemispheres. So looking at the details of the cerebral cortex, you want to see a multitude of certain types of structures here. In particular, you want to see what's called the gyrus, which is going to be the outcropping of these particular folds. You're going to find a little sulci as well, which is going to be the plural of sulcus. It's going to be a little bit of infolding inside the brain and the gray matter in particular. And you're also going to see some fissures there as well, which is a really deep partition from one lobe to the other. If you look at the superior shot of the brain there, you can see three different lobes there. You have frontal, it's most anterior, followed by the parietal, followed by the occipital going most posterior. If you look between the two frontal lobes, two parietal lobes, two occipital lobes, left and right hemisphere, they'll be separated by the longitudinal fissure. And one other thing I want to point out too is you're going to find a central sulcus, which is going to partition the frontal lobe to the parietal lobe. Very important because we're going to talk about both the pre and post-central gyri in relation to how well they control both motor and also sensory function. So the 5 lobes found in the cerebellum are going to follow the same progression that we use, with the exception of one. Same progression that we use with the cranial bones. So you're going to have a frontal lobe, it's going to be protected by the frontal bone. The parietal lobe will be found just deep to the parietal bones. The occipital lobe, and then the temporal lobe found on either side, most lateral. Now, deep within the cerebrum is going to be known as the insula, which is going to be the most lateral partition around the lateral ventricles, and it's basically going to partition the midbrain or the diencephalon from the rest of the cerebrum. Now, remember I talked before about having a lot of gyri, a lot of sulci. Okay. Unfortunately, we've run into a problem with you have not enough of these infoldings, which means there's not enough neural connections known as lissencephaly. This person basically has a very abnormal brain. These people generally do not live very long, maybe about 10 years life expectancy, very simply because of the lack of neural connections. Certain body processes start to fail. Those of you who ever watched the movie Young Frankenstein, and again, I'm probably dating myself because Young Frankenstein is a Gene Wilder movie that was done, I think, back in the late 70s, early 80s, done in the old-fashioned black and white. Talked about using the brain abnormal. This basically was a very poor-looking brain with very poor types of connections to it. So anyway, that was a brain that they put in the Frankenstein's monster. So that basic person had lissencephaly. Here's a very interesting slide where they've taken all the gray matter away from the brain, and all you're left with is the white matter. So this shows all the different kind of connections that are found within the brain, and we basically will categorize them in 3 ways. You have association tracts, which are going to be white tracts within the same hemisphere. You have commissurial tracts, which is going to go back and forth between both hemispheres in the same location. So let's say if you have one center on the left frontal lobe, you actually track over to the right frontal lobe in exactly the same spot corresponding to the hemisphere. And of course, these travel through the corpus callosum, which you're going to find almost dead center there in the mid-sagittal plane. Finally, you're going to have the projection tracts. You're going to travel to the inferior portion of the central nervous system. So in this case, you can go through the brainstem and also travel down through the spinal cord as well. So next we'll look at the really deep part of the cerebrum called the basal nuclei. These are very important because these are going to be very important for both starting and stopping certain types of motions. So your 3 basal nuclei are going to include the caudate nucleus, the putamen, and the globus pallidus. So these are very important if you can imagine, especially if you've ever been on a diving board. It's that last little bit of apprehension you have before you're about to jump off the diving board. It's these basal nuclei help you coordinate whether you want to jump, how you're going to jump, and once you jump, how you're going to hit the water. And as you're going through the air, whether you want to jump in as a cannonball or try and go in cleanly feet first or head first. So these are very important to help coordinate with the pons, the medulla oblongata, as well as the cerebellum, and also certain portions of the cerebral cortex about starting and stopping certain emotions. This was known as the limbic system. Everything you see shaded here in green. Now, I don't need you to know all different shaded areas. I'm going to point out 3 different parts here in particular. This one is known as the emotional brain, also known as the primitive brain. Basically, you're going to look at 3 different structures, which is going to be the hippocampus, which you're going to find just posterior and lateral by the temporal lobe. Right now, it's distinct for a couple of different reasons. Number one, it's the only area that we know of currently in the central nervous system that is going to mitotically divide. So it's constantly replenishing itself in the hippocampus. Also is very important for inherent connections with memory in particular. The next one we'll look at is the amygdala, which we found just a little more anterior to that, a little more lateral into the temporal lobe. This is where most of your fear, aggression, and rage is going to come from. In some people that are sociopathic or psychotic, a lot of times removal of the amygdala will take away a lot of the very aggressive type of responses that you see. The last one to point out is the olfactory bulb. The hippocampus is very strongly attuned to smell. So this goes back to, if you look at the, again, evolutionary standpoint, for a chance of survival, we learn to smell or recognize certain scents that will put us in danger. So naturally, if you have a certain smell and it makes you very fearful, then your brain knows to get you out of there as soon as possible. Or it will instigate some kind of flight mechanism. That's where the rage and aggression will come into play there as well. But again, just three components I want you to be aware of here: hippocampus, the amygdala, and the olfactory bulb. But all these parts, the whole green shade area, is known as the limbic system, or the emotional or primitive brain. So again, three areas: the limbic lobe is going to be the hippocampus. So again, the only area in the central nervous system that's going to mitopically divide, very important for emotional connections to memory, and it's going to tie into both the amygdala and also the olfactory bulb in particular. So you use a lot of fear, rage, and aggression. Excuse me. And of course, odors a lot of times can produce certain types of emotional response. That's why a lot of times when we talked about the different types of odors that would be very important with the pineal gland, we would have certain types of responses, whether it be love, whether it be comfort. Sometimes, again, you feel very aggressive with certain odors. But this is all linked in through the limbic system. So here are two of the latest things I could find regarding the hippocampus and being able to generate more neurons throughout the person's life. One is through stem cell, and one is through nature. Different volumes are left there for further reading. So there is some promising news. This I got off of Twitter Science News, I guess probably just 2 semesters ago, give or take. I found this just after this was posted. So they're looking at what's called neurogenesis, which is generation of new neurons in the adult central nervous system that's generally unheard of. So naturally, they're testing this to see what kind of neurotransmitters involved, what genes could possibly be turned on to help improve any kind of central nervous system production. So it looks promising. Now look how the cerebral cortex is going to be organized from a functional standpoint. So basically we're looking at 3 different types of areas. We're looking at either sensory, motor, or association areas. So association areas will a lot of times will transmit information both to and from motor and sensory areas. And this is based off of Brodmann's map, which was developed back in 1909, which basically mapped different types of brain injury patients. So once we knew like certain area of the frontal lobe and we started to correlate with different types of examinations of those people, we started to realize that the frontal lobe was very important for personality, for memory. We saw different types of injuries there. We noticed people have deficiencies in those particular types of functions. Now, Brodmann's map, they would use different numbers to associate with different portions of the cerebral cortex. I believe there's 59 different areas. A lot of them have been taken back and basically fused in some areas. So I'm not going to expect you to know all the different areas. There's only a few spots I'll have you kind of focus on here and there. So just don't be overwhelmed when you look at the map coming up. So the sensory areas we're going to talk about for the most part in the cerebral cortex. The primary sensory area is going to be the sensory homunculus. This basically is a distorted body map. Most of you have ever watched cartoons before as kids. Naturally, everything is distorted. A lot of times the head will be a lot bigger than the rest of the body, or someone has big hands or has big feet. Usually what we see in the primary sensory area very simply is different areas are dedicated to highly sensitive areas. So for example, you would assume that a large portion of the sensory area maps out the entire the hand, it maps out the feet, maps out the face in particular. There's a lot of portions that are dedicated to the lips, to the tongue, whereas you have a very small portion that would be dedicated to, say, the small of the back, or to the lumbar region, or to, say, the anterior thigh. Other areas include the primary visual areas, auditory, gustatory, which is for taste, and olfactory for scent. So again, this is Brodmann's map. This has been updated quite a bit. So a lot of these areas here, as far as the primary areas, we'll point out again. So at the primary sensory area is in the post-central gyrus. This is going to be found in the parietal lobe. You're going to find the primary visual area found in the occipital lobe. You're going to find the auditory area very close in the temporal lobe. You're going to find the gustor area very close to that as well. The olfactory area is going to be found just inferior to the prefrontal cortex. Now, as far as the motor areas of the cortex, again, the primary motor area was going to be the motor homunculus, which is going to be a little bit different than the sensory homunculus, although there are a lot of parallels there. So basically for fine motor control, so for the eyes, for the mouth for speech, for the lips for control of speech, and also for control of chewing, so on and so forth. Naturally, the hands, the fingers, the feet. Basically, less area is going to be more so for the lumbar spine, for the hips, and for the proximal portions of the limbs, so the humerus area as well as the femur area. The other thing I want to mention too is Broca's speech area, which is on the left hemisphere for most people, although some might be more right hemisphere dominant. These are basically for control of breath and coordination of the vocal cords for speech. So damage usually we'll call what's called non-fluent aphasia, which basically means that they stutter, which again, I've stuttered for quite a while when I was a kid. I tend to slur my speech a little bit there as well. Now I'm left-handed, which generally means that Broca's area is not as well dominated on the left-hand side. So in my case, Broca's speech area is mostly on the right-hand side. These people can very easily think clearly, but can't really form words very well, can't articulate very well either. So here we see the primary motor area found in the presensory gyrate. This is going to be found in the frontal lobe. And as you can see, deep in number 44 and 45 is Broca's speech area found in this portion of the right hemisphere. So most people it's going to be dominant on the left side, but again, you do find Broca's speech area on the right side as well. But most people it's going to be left side dominant. So your association areas, you're going to find these pretty much interspersed all throughout the cerebral cortex. For the most part, I don't expect you to know exactly where you're going to find these, but I do want you to be able to identify what these areas will control. So for somatosensory association, it's going to be memories and touch. Visual association for recognizing objects both in the past and also the present. The facial recognition area is usually on the right hemisphere dominant. Very, very important for babies as they develop to be able to figure out who their parents or relatives are. Again, facial recognition is very important there. You have the auditory association area for speech, music, and noise. Orbital frontal cortex is for odor recognition, and mostly is going to be right hemisphere dominant. Wernicke's area is going to be, basically there's damage here. This is different from Broca's area where someone can think clearly, but a lot of times the words may not be articulated completely. Whereas Wernicke's area, if there's damage here, you have what's called word salad. So very simply, if someone said, put the burgers on the grill, so they would say instead, complete nonsense. They would say something like, put the horse in the car. So a lot of times what they're thinking does not actually work as far as putting it into words. And I'll come back to that in just a couple seconds here. You have the common integrative area, which is going to be the variety of sensory input. The prefrontal cortex is very important because it's going to house your personality, your intelligence, also your reasoning center. So naturally, people that have injuries to those particular areas, a lot of times there's no common sense, let's say, or they can't reason, or they don't know they can't cross the street on a red light. Or a lot of times they may actually will shift in different portions of personality. Some people become more complacent, some people more violent after injuries to the prefrontal cortex. You have the premotor area, which is going to be where you're going to store most of your memory and coordinate and learn motions. So this is where you're going to find areas that help you learn how to ride a bike, or throw a ball, or how to balance yourself, how to swim, so on and so forth. And the last one would be the frontal eye area. This one is going to help you learn how to read and recognize words. Now, one little thing I want to mention as well here, in particular with Wernicke's area, as well as Broca's area. This has to do with speech. One kind of therapy that some speech therapists have used in particular is singing a certain answer versus speaking it, are found in two totally separate portions of the cerebral cortex. So the way they've gotten around Wernicke's area abnormalities or any kind of injuries is people can sing their answers or sing in conversation, and it comes out completely fine. So this is a very common type of therapy that people use with different types of brain damage victims. These can do the stroke, they can do the concussions, or different types of necrosis, so on and so forth. But there's a lot of good information out there for brain injuries and how to circumvent certain types of problems in the brain. Okay, here's the cerebral cortex. I want you to do a quick run around the periphery of the cortex here. So looking at the somatosensory area found deep in the parietal lobe. Going further down, the common integrative area. You got the Wernicke's area, just lateral in the parietal lobe there. Visual association area will be found just above the primal visual area in the occipital lobe. The auditory association area found very close to where the ear is in the temporal area. So it's going to be very close and very integrated with the primary auditory area. The prefrontal cortex, also with the frontal eye field area. So these are all areas that work in association with both motor and also with sensory centers within the brain and also through the spinal cord. So critical thinking. So remember I talked about the corpus callosum before. So women tend to have less hemispheric lateralization or less specialized areas of the brain from one hemisphere to the other, and a greater corpus callosum by 12% than men. Would you expect women to be more or less susceptible to stroke or other cerebrovascular accidents than men? So let's kind of clarify some of this a little bit. So hemispheric lateralization very simply means that one side of the hemisphere of the brain is more dominant than the other. So what we find is women have less specialized or less switching from one hemisphere to the other than men do. So men in general, and again, this is a very general statement, men generally are being more lateralized as far as where the centers are. So in particular, Broca's area is more in the left hemisphere. For men, Broca's area is more evenly out or evenly stretched out between both hemispheres for women. Now, knowing that the corpus callosum is greater, has a better connection from hemisphere to hemisphere for women, who is more susceptible to stroke or a cerebrovascular accident, which means stroke or any kind of bleeding or any kind of trauma? So the answer is very simply women. Unfortunately, for us men, and of course all the women will probably have a nice little snicker to this, women are more apt to bounce back from any kind of injury to the brain than men are. Now again, very general statement, there are certain individuals that might have a greater corpus callosum than others, but in general, women are actually more resilient to other types of injuries to the brain than men are. Now what can you do to help this out? Basically doing all kinds of activities, any kind of cross-body activities to basically try and help things out and trying to improve the amount of greater connection of white tracts to the corpus callosum on both sides. Now on the flip side, so there are some people who have such a great connection with the greater corpus callosum where they're susceptible to different types of seizures. Some of you may know some people that had seizures before. Some people that even had some of the worst of the seizures, called the grand mal seizures. I've had patients that have had seizures in my office. It's one of the scariest things that I've seen, especially in my office, where there's nothing you can do. Pretty much your best option is to try to move as much furniture out of the way as possible as the person goes through convulsions. The old school thought used to be to put a wallet or something in their mouth, but very simply, when someone has a seizure, it usually means they're having almost the entire portion of some muscles contracting completely, which can be very strong. So nowadays, we've been told not to put anything in the person's mouth for fear of actually biting your finger off. So very simply, just let them go. It usually lasts a couple seconds to a couple minutes. Just trying not to let them hurt themselves as they may smack into pieces of furniture back and forth. I mention it very simply only because the first common treatment for uncontrollable seizures that do not respond to medication, they actually will cut the corpus callosum, which actually makes things very interesting, because when you lose that connection between both hemispheres, you'll find a lot of times doing things on one side of the body, the mind is not quite perceiving the other side of the body quite as well. So literally you can do something with the left hand and the right hand doesn't know what's going on. It actually makes things very ambidextrous in that sense. So again, in general, and again, everybody's going to be wired a little bit differently. So basically look at the left hemisphere first. So traditionally, most people, most of your somatosensory signals will control the right side of the body, of course. Your left side hemisphere is most of where your reasoning centers are, most of your scientific and numeric skills, and also your language centers, both spoken as well as written. So a lot of times people that have issues with the left hemisphere, a lot of times will experience aphasia. Now the right hemisphere tends to be a little bit different. Naturally, the right hemisphere will control the left side of the body. These tend to be a little bit more awareness with music and art. They tend to work better with space and pattern recognition. So 3D models, pilots tend to have better right hemispheric function. People that work in the oceans, where 3 dimensions is very important, of course, they're very good at using with their right hemisphere. Recognition of faces, emotional content of language, be able to identify different types of orders. But a lot of times you'll have problems with Broca's area and Wernicke's area, where a lot of times they'll have problems learning how to do speech, or at least have some kind of emotional inflection with the kind of words that they say. We're going to touch upon brain waves very, very simply. This is basically an electroencephalogram, which measures brain waves in different functions. So we're just going to go through a very brief definition of each one. Your alpha waves are your basic waves you're going to find once you're conscious. Once you go to sleep, then these waves kind of go away. Your beta waves are normally found under areas of intense study or while you're reading or when you're trying to concentrate on any particular types of activity. Theta waves, a lot of times you'll see these when people experience emotional stress. They tend to be a little bit stronger in children than adults, but that can vary quite a bit. Delta waves are found mostly when you're asleep, although sometimes you'll find these in some awake infants. But generally, if you find delta waves in an adult while they're awake, usually means there's severe brain damage in that particular area. So now we get to the cranial nerves. The cranial nerves are going to be named by Roman numerals 1 through 12. A lot of times you'll see them abbreviated as CN1, CN2, and so forth, or a lot of times they're simply named by the actual nerve itself. Now these are going to be akin to the spinal nerves that we find up and down the spinal cord. Now these are going to be, sometimes they're going to be purely sensory, sometimes purely motor, and then some will be mixed. But this chart and next slide also will give you a nice little representation or a nice brief synopsis of what each cranial nerve performs. So first we start with the olfactory nerve. So it's going to be all sensory. It's only for olfaction or smell. Your optic nerve, cranial nerve number 2, also sensory, just solely for vision. Optic nerve number 3 is going to be all motor, but it's going to be somatic and also going to be autonomic. So somatic means that you control it. It controls four of the muscles of the eyeball plus the upper eyelid. Motor and sensory is going to help you adjust for accommodations. That's the one where you focus on your finger and you bring it closer and closer to your nose until the eyes go into a cross-eye position. That's called accommodation. We'll talk about that a little more in depth when we get into the corresponding lab towards the end of this semester. Also works with constriction of the pupil in bright light. Your trochlear nerve, cranial nerve number 4, is going to be motor. It's going to be movement of the superior oblique. If you guys remember SO4, this is the cranial nerve that we're talking about. So it's all motor there. Trigeminal nerve is going to be your first mixed nerve. It's going to be both sensory and motor. So for sensory, it's going to be basically all the sensations of the face and scalp and portions of the oral cavity. It's also going to work on the touch for the anterior 2/3 of the tongue. Not taste, but for touch. It's also going to be for motor control of the muscles of the jaw. It also controls the middle ear muscle. The abducens nerve number 6. Cranial nerve number 6 is going to be all motor. This controls the lateral rectus of the eyeballs. Facial nerve number 7 is going to be also mixed. So sensory, this will actually work on taste for the anterior 2/3 of the tongue, but also touch pain through the external ear canal. Motor, in a sense, is going to work on some of the muscles of facial expression, which we talked about before. It also works with the autonomic system for secretion of tears and for saliva. Cranial nerve number 8, the vestibular-cochlear nerve, is all sensory, but it works on 2 factions, both hearing and also with equilibrium. Glossopharyngeal is going to be a mixed nerve. First for sensory, is going to basically innervate the taste for the posterior third of the tongue. Also proprioception in some swallowing muscles, so basically knowing where certain things are falling in through your throat. Also monitors blood pressure and oxygen and carbon dioxide levels in the blood. Also works on touch, pain, and thermal sensations in the ear and also the upper pharynx. This is motor and sense where it assists in swallowing, so most of your hyoid muscles, but also autonomic with secretion of saliva. Now, vagus nerve, cranial nerve number 10, is known as the wandering nerve. This is going to travel pretty much through the thorax and also through the abdomen. It's going to partially work as a sensory organ for the sense of taste on the epiglottis. Yeah, we actually taste on the epiglottis. Also works with proprioception of throat and voice box, monitors blood pressure, touch, pain, all throughout the external ear, also sensations around the thoracic and abdominal organs. So from a motor standpoint, it's going to work in conjunction with the glossopharyngeal nerve, swallowing, vocalization for coughing, and also for the autonomic portion, this can control the organs in the gastrointestinal area, as well as the heart, and also different areas along the respiratory tract. Now I want to go back real quick to the brachial portion. Generally, we do the cough test in practice. We use the tongue depressor. This is the one that actually will induce the gag reflex. Normally, we don't do this in class, although we usually do go through some of the cranial nerves. The vagus nerve, we usually just have people cough. It's usually enough to give us a good test to see whether there's any problem there or not. The accessory nerve, cranial nerve number 11, you should remember this one from the muscle system chapter. all motor. It's going to take care of two muscles. It's going to take care of the sternocleidomastoid and also the trapezius. And finally, we have the hypoglossal nerve, which is cranial nerve number 12, also somatic, only motor. So this is going to work with speech, with movement of the tongue, manipulation of food, and also aids in swallowing. So the mnemonic they give you for cranial nerves, I never had a good one back in school, but this is one they use. OOO, to touch and feel, very green vegetables, ah. So there you go. That's not the best one I've heard. I don't know any real good ones, but if that works for you, then hey, that works for you. So here's the same actual nerve system overview they looked at. We looked at the cranial areas, different portions of the brain. There's a different portion for the cranial nerves as well as the spinal nerves and the spinal cord. So I won't waste your time if you want to look at that again. The next couple slides will actually partition each individual cranial nerve, give you an idea where they branch from, and also what they actually attach or innervate or synapse with. So here's the olfactory nerve, cranial nerve number 1. So you have the olfactory bulb and olfactory tract. These are going to basically will synapse in the cerebral cortex. We'll go through these a little more in depth when we get through special senses. So very simply, the olfactory bulb is going to basically sit on the cruciform plate of the ethmoid bone. It's going to sit just superior to the olfactory cavity. It's going to have different olfactory receptors, excuse me, that when you have mucus around will help you bring in certain types of sensory receptors to life to basically allow different types of odorants to basically adhere to the olfactory receptors and generate the nerve impulse. The optic nerve is basically gives us sight. So this basically gives us our blind spot on the eye. This is continuous with the optic chiasm. We'll also synapse deep in the cerebral cortex. We'll go through the full track when we get into the special senses chapter, which will be the last chapter we'll do. But without the optic nerve, you basically blind. But this will innervate with the retina. So basically, it'll expand upon all the different neurons, the rods and cones that we'll look at later on, to detect different light patterns and start the actual nerve impulse. Oculomotor nerve, so it's going to innervate to 3 different sets, to 4 different muscles of the eye plus 1 muscle of the eyelid, and also is very important for the combination reflex as well as the constriction of the pupil. You're going to see the same slide. You notice here is also the trochlear nerve, also the abducens nerve there as well. Oculomotor nerve is going to branch off the pons. Later you see the same slide for the trochlear nerve number 4, and also number 6. I'm sorry, I misspoke. The oculomotor nerve is going to branch off of the midbrain. Next, you're going to look at the trochlear nerve. So that's going to control only the superior oblique muscle. This also is going to originate off of the midbrain. And there's the trochlear nerve. So next, we're going to look at the trigeminal nerve, cranial nerve number 5. So if you notice, this one has a ganglion just lateral to where it originates from the pons. So you're going to have 3 branches here. You're going to have the ophthalmic branch, which is going to innervate from a sensory perspective from the frontal area as well as the orbital area. The maxillary branch was going to be around the maxilla as well as the nasal area. And then finally, the mandibular branch was going to do 2 functions for us. It's going to split into the motor area. You can see the muscles there, the temporalis major and the 2 pterygoids, and also going to innervate sensory for areas around the mouth and also around the ear. Abducens nerve, again, off the same slide, is going to be cranial nerve number 6. It's going to be a motor nerve, and only for the lateral rectus muscle. It's going to branch off the pons. Facial nerve. So the facial nerve is going to do 2 things for us. It's a mixed nerve. It's going to basically control all the muscles of the face and facial expression, but also work from a sensory perspective for working around the nose and around the tongue, and also from an autonomic perspective, we'll work with salivary glands there as well. This will also originate from the pons. The vestibular cochlear nerve, the cranial nerve number 8, this is going to share connections with both the pons and also the medulla oblongata. It's going to have 2 branches. It's going to have the vestibular branch as well as the cochlear branch. The vestibular branch is going to be more for balance coordination. The cochlear branch is going to be mostly for hearing. But again, we'll go through this a little more thoroughly when we get into the special senses chapter. So the glossopharyngeal is cranial nerve number 9. This is going to be a mixed nerve. So this is going to allow you to have sensation of taste around the anterior 2/3 of the tongue. Also, from a motor perspective, will assist in swallowing, also the secretion of saliva through the autonomic nervous system. This will also, from the side, also will monitor blood pressure. That's why you see the carotid artery and the carotid sinus. So this detects different types of changes in blood pressure. Also, for some portion, also allows proprioception of swallowing muscles. So again, this helps you in particular with detecting food as it goes down your throat. This also has a ganglion, but has two, both a superior and inferior ganglion. You also have an otic ganglion. This can be found just anterior to the ear at the parotid gland. Vagus nerve, again known as the wandering nerve. So this can be also a mixed nerve. So this will allow you to get taste from the epiglottis, also proprioception for the vocal muscles, and also helps monitor blood pressure along with the glossopharyngeal. From a motor aspect, it's going to help you with muscles of swallowing, also for speech, and also to aid in coughing. From a motor autonomic sense, it's going to work on the heart for heart rate, different areas of the gastrointestinal tract, including the liver, gallbladder, stomach, also the small and large intestine. This also will have both inferior and superior ganglion. Accessory nerve is going to be purely motor. This is going to branch off the spinal accessory nerves, or the spinal nerves, as well as the medulla oblongata. It's going to control both the traps and also the sternocleidomastoid. Hypoglossal nerve is purely motor. It's going to control most of the hyoid muscles, the genohyoid muscles, and the glossus muscles. This is going to branch also off the medulla oblongata. So cranial nerve origins, again, just another cheat sheet for you. So olfactory nerve is from the temporal lobe. Optic nerve is from the optic chiasm. This is going to be from the cerebrum. Ocular 3, trochlear 4 from the midbrain. Trigeminal 5, abducens 6, facial 7. And one portion of the vestibulocochlear from the pons, so the vestibular portion from the pons. From the medulla, you're going to get the vestibulocochlear, the cochlear version, the glossopharyngeal, number 9, vagus 10, hypoglossal 12, also from the medulla. Spinal accessory will get most of its innervation from the medulla, but a portion from the C1 through C5 spinal nerves. So basic development of the nerve system is going to be starting from thickening the ectoderm called the neural plate. That's all I need you to know. I probably will not test you very much on this because this does get quite involved with developing the nerve system. Again, I feel like this is more so for an embryology course than for human anatomy. So I mentioned this area just for academic sake. Remember we talked about spina bifida. Basically, this is what happens when the neural tube doesn't fully encircle the area. So basically called neural tube defect is the start of spina bifida. So this is where the somites will start to branch from off of this area through here. And then basically the posterior portions of the vertebral body doesn't form properly. So that allows the spine to start actually progressing more posteriorly and sometimes poke through the skin and creating the different types of spina bifida that we see. If we see spina bifida occulta, it's usually still enclosed, which means that the lamina is not fully ossified. But spina bifida manifesta, that's where we actually have the spinal cord or the sac where myomeningeal starts to protrude through the skin. Now, as aging, there's no real surprise. We start to lose our neurons, start to lose your interconnections or synapses in certain areas. So there's diminished capacity for sending nerve impulses to and from the brain, so they can't sense things very easily. They can't react to things very easily. They're generally slower as far as reacting to things, slower to process certain things. You start to see a decreased conduction velocity. This could also mean that myelin sheaths could be degrading. You see, of course, slowing of voluntary motor movements, more reflex time, also degenerations in all the special senses too. So if they start to lose their vision, they need aids with glasses, sometimes bifocals. Hearing, possibly hearing aids. Sight, they can't taste things. Those of you who've been around some older people, they need spicy things in order to taste things. They lose their sense of smell, touch, and also the balance as well. So this comes as no surprise to most of you. Some of this can be augmented a bit by simply staying active in your younger years and trying to maintain that as much as possible. But over time, we do start to lose, the neural connections, whether it be the neurons die off, or a lot of times synaptic connections just don't work as properly. So different types of disorders. Homeostatic imbalances could be kind of a delicate term. Some of these are severe homeostatic imbalances. You have a cerebrovascular accident known as a stroke. This is something we touched upon back when we talked about the lateralization of hemispheres. Some people can get a minor stroke or like a transient ischemic attack. It doesn't leave any kind of permanent damage, but it does cause some disruption. But if you have a TIA, usually you can bounce back from this relatively quickly if they can catch this early enough. But if we get back to strokes, though, strokes are extremely dangerous. because you can have any type of rupture of a blood vessel, which can cause hemorrhaging or internal bleeding. You can cause an embolus. It could actually loosen up, that we had talked about before, with a thrombus, let's say from an old fracture, let's say in a long bone. If that ever dislodges as an embolus and will actually lodge itself in some of the small muscles, small vessels, found in the brain, can cause a lot of necrosis and therefore cause a stroke. This can cause permanent damage and or death. Thankfully, though, if you suspect a stroke, if you can get them with a plasminogen activator within 3 hours, it's very effective. Even though you may lose some brain cells here or there, you're not losing the entire area. So people can bounce back with this very quickly. There's a lot of different factors out there, a lot of different outward signs for stroke. Some could be very simply a person all of a sudden can't speak, or a person all of a sudden just stops and doesn't move anymore, or let's say they see a certain drooping in the face, or they can't raise their arm. There's a lot of different things out there, especially in the elderly, or people that are diabetic, or if they're known to have atherosclerosis. These are all pre-existing factors that could make it more susceptible to a stroke. Smoking is another great one too. Lack of exercise is another one as well. Sometimes there are different kinds of diseases, like Alzheimer's, where very simply the acetylcholine, a very major neurotransmitter, is simply less abundant. So having that synaptic connection just doesn't work properly. The hippocampus can deteriorate, and we know obviously the hippocampus being the only area that can actually mitopically divide, losing that can really put you on a downward spiral. You can cause plaquing, neurofibrillary tangles, which very simply means you start getting scar tissue in those areas, and then basically where certain neurons should be inhibited, a lot of times they may be activated, and then a lot of times you'll get lack of any kind of memory. You can't actually pull those memories back into the forefront. That's why a lot of the things that you may be talking about recently, you might tell them a joke, then 3 hours later you tell them the same joke because they don't remember it. But a lot of times this happens with the more recent synapses that were created. Some of the more deep-seated synapses, like obviously memories from childbirth, from childhood, and early adulthood. A lot of those can still be maintained, but it's usually the newer types of experiences they have problems remembering. And finally, we talk about ADHD. This is both a genetic and also an anatomical disorder. Some of the areas of the brain may not be fully developed. Different types of medication, like Ritalin, has been most prevalent with this kind of thing. Behavioral transformations, but that goes a little more deeply into a more almost like a behavioral type of class, more so than anatomy and physiology. But these are some very simple examples of some of the problems with the major disorders with the brain. This finishes up this chapter. We'll move forward into the autonomic nervous system next, which is relatively short. We should have it done in less than an hour or so. So you should be able to zip through that relatively quickly.